Good afternoon, everybody. Thank you for joining us today for Leveraging AAP Bright Futures to Improve Maternal Health Outcomes. We're happy to have Molly O'Neill Bradshaw here with us. Molly is a certified family and women's health nurse practitioner, and we're lucky enough to have her help us with this implementation of Bright Futures. I'll turn it over to you, Molly.
Okay. Thanks, Ashley. And thank you to KPCA for inviting me and for letting me be a part of this effort. I know we are all looking for ways to improve maternal health. And so, what I just wanted to share in this session today is some practical little ways that you can implement some of the content for Bright Futures, which I know we think of as a pediatric tool, but there are some components of it that speak very directly to some of the maternal health outcomes that we're interested in. And because of that, there's just some specific pieces that we can pull out. And as a leader in your organization, you can share that with your providers and find ways to bill for some of the things that we're going to talk about in the session. Just a little bit about me. I am a nurse practitioner, as Ashley said, at Cumberland Family Medical. I work in the Russell Family Medical office. I do that full time. I do a lot of consulting and speaking for another number of other organizations, but I have no conflicts of interest to disclose in this presentation. At the end of this, I'll show you this QR code again, but I've got a snapshot to this slide deck and to all of the resources that I'm going to talk about in this. We'll show this code again at the end. And then also, because KPCA is providing this resource to you and your organization, Bright Futures, you can get your copy. We'll show you a way that you can order that for your organization if you've not already done that. So, what are we here for? What's our objectives? I have a very strong belief that if we are going to improve maternal health outcomes, that is really the responsibility of primary care. Yes, OBGYN offices are partners in primary care, but I believe that we're missing some opportunities to interact with mothers and improve some of these things in the more traditional primary care setting. We can be a safety net for these moms, but this is kind of a different workflow for primary care. We don't tend to think of OB patients as much or perhaps as often in our regular primary care settings. And what materials are there out there that help us do that work? Well, the American Academy of Pediatrics is one of the publishers of a clinical guideline called Bright Futures. Bright Futures is also endorsed by the American Academy of Family Physicians, as well as a number of other organizations. But basically, this is a collaborative guideline that kind of helps us have a roadmap for all of the things that need to happen from that prenatal all the way up to a child being born. So, in this session, I want to talk about some of the things in this that are rapid, very achievable workflows for you to get some of these recommendations into play and into practice, especially as it speaks to moms. So, we're going to talk about Bright Futures, talk about the workflows and how they integrate. I want you to leave here with at least 3 things that you can do today to get this going and get this off the map and or onto the map with your care. And just how do we utilize that further? One of the big tenets of Bright Futures is that it makes a very clear statement that we treat families, not children. It clearly states in these guidelines that all children belong to some type of larger nuclear family. And so, in essence, that essentially means they have a mother, they have a father, maybe a grandparent, a caretaker, they're part of the foster system. But all of these kids have, a mom eventually when they're born. And in OB care, we would never take care of a mother without also assessing fetal well being. So I would argue and put to you all that we should never separate mom and baby as we design care for what's going to happen when the baby delivers. Mom and baby should be a completely integrated unit as we start to plan for, especially the first year postpartum, and we start to get into other things like maternal depression, maternal hypertension. We're treating both patients. So there's opportunities to leverage this. And I believe that, especially in these first interventions, when baby's born, let's say baby is born, baby goes to this first newborn visit, the mom is right there and we're missing them. We're not screening them, we're missing them, and we wonder how we can improve these maternal health outcomes. Well, they're right there under our noses. So we want to change that, and here's how we're going to do it. It's Bright Futures. We're going to leverage that. So here's a picture for you of what material KPCA is providing to you, right? So again, it's this multidisciplinary guideline. It's pre-designed. It is literacy appropriate. One of the things that I love about this guideline is when they developed it, and they're now on their fourth version of it, but when it was developed, it was written with the awareness that anyone who cares for children should be able to read this. So this is written actually at a sixth grade reading level on purpose because we knew that teachers would be reading it, guidance counselors, dietitians, maybe emergency personnel. Yes, there would be pediatricians. Yes, there would be nurse practitioners, PAs doing primary care, but there are also daycare workers, policymakers, everyone. So this guideline is for everyone. It comes with the big picture that you see here is the book. It's rather a large book. I'll hold it up for you. There's a pocket guideline that comes to it. That's what you'll get from KPCA. And then when you get online, there are some additional tools and resources that you can get on and download. I'll show you those in just a second. And there's even a nutritional guide that is free to download and free to access to talk through all of these nutritional pieces that we go through with families. The organization of this book is that it's first organized by, you can go ahead and flip, Chuck. Um, this is first organized by the age of the patient. So Bright Futures has 4 categories that they organize patients into. So it's prenatal to 9 months. Early childhood is defined as 1 to 5 years. So in those years, getting them ready for kindergarten, right, to get into the school system. They've got middle school, middle childhood, so basically the 5-year-old to that 11-year-old. And then adolescence on this guideline is considered the 11-year-old all the way up to the 21-year-old. So it's organized in that layout by that age group. Also, this guideline is organized by what is called themes. So these are the chapters that are in the book. Bright Future calls them themes. And so as you read through this, promoting health for families and communities, family support, healthcare special needs, I won't read this to you, but it's going through piece by piece by piece all of the things that contribute in. So oral health and how we do oral health screenings in primary care, all of it is there. Physical activity, nutrition. So think even about pediatric obesity. Think about the mothers that we should be counseling on, getting them enrolled in WIC and getting them in those pre-healthy food choice things when they're pregnant. All of that is discussed in these chapters. The newest chapter that has been updated to this is the safe use of social media. And oh gosh, we could talk all day about that, but basically giving some very specific rationale and reasons of how to manage, limit, and safely promote use of social media. So it's a great chapter too. Next up, we've got this periodicity schedule. This is a little overwhelming, so let me break it down for you. This is your one pager. If the internet blew up and you were no longer able to access your electronic health record, or even if you have an electronic health record, this is a one-page map of everything that should happen at every pediatric well child exam, cradle to 21 years old. Everything that you see on this, where you see a dot, means that it is recommended to be implemented at that visit. So you see by color your 4 age groups we talked about, that infancy, early childhood in yellow, middle childhood, and adolescence. Each one of these visits in your toolkit that you can get online and access has a corresponding patient encounter. And that includes a pre-visit questionnaire that you would give to the parent or family. They would complete it when they sit in the waiting room. There is an age appropriate clinical encounter for the provider to tell them exactly what they need to do during this visit. And then there's another sheet that's got what we would call anticipatory guidance of what to do, what to expect as baby grows, as child gets bigger, what's going to be expected for the next piece of growth and development. So going down your left-hand column is the organization of all the things that need to happen, like history, measurements. So it will tell you, for example, blood pressure management in a kid starts when they're 3 years old. You don't measure blood pressures earlier than that, at least during routine childhood visits, right? Oral health, when do we do lead screenings? All of that is here on this one page. The star means it might be recommended depending on the situation of the child or the demographic kind of environment, regional area that you're in. But if you ever need to look at the one page, here it is. So those forms correlate back to this. Again, if we were to ever lose our ability to look through and we just had to do old fashioned analog writing it down on paper, this is telling us exactly what we need to do. But you'll hear us talk about the periodicity schedule. This is an example of your workflow templates. Now, I would wager that any electronic health record that you are currently using, and my organization included, right? To the extent that we can, we need to make sure that these EHR workflows map into the recommendations of Bright Futures, right? So on your left-hand side, this is an example of that pre-visit questionnaire. The middle is the encounter form that the clinician would use, and the one on the right is the handout that we would send home with the families. You see that it's labeled the 1 month old visit, there's a 12-month visit, there's one set of these for every single visit that's dotted on the periodicity schedule that I just showed you. Also, as part of your toolkit that you can get online and get, there are some PDFs of developmental screenings that are recommended. So in pediatrics, we talk about surveillance, that at every contact with a child, we should be on our toes and looking for speech, cognition, different things. And that at certain points across the continuum, we should do formal screening, like when do we do autism screening? When do we do Denver 2 ages and stages, etc. So one of the things that I want to point out to you related to maternal health is that maternal depression is a recommended screening at the newborn 1 month old visit, also at the 2 month, 4 month, and 6 month visits. They are recommending that we screen moms for maternal depression. I'm going to put to you and urge all of us, myself included, that we should expand that to also include screening for maternal hypertension. Mom is right under our nose. There's no better opportunity than to just check her blood pressure. And it's easy. You don't have to check her in. It just is a simple, do you want me to check your blood pressure while you're here? Check it. And then we're going to have protocols in place for what to do next. Next slide, please. A quick mention about the nutrition guide. It does speak to some things related to mom, particularly in relation to the prenatal nutrition. It talks about breastfeeding, and it talks about mom's role in helping families have good nutritional habits. So you can get online and get the ebook, but you can also download the free pocket card here, or I'm sorry, the pocket guide. Really a great read. And I got to tell you, if you have kids in your own life, you need to read this, because this will either make you feel like the parent, grandparent of the year, or it's going to make you question some things that you're doing. But it's a great resource. Next slide. Read it for the sake of knowing about mom. One of the key things we talk about in that nutrition part is that 5210 message. So if you are running a school-based clinic, if you are running any type of community-based resource, we all need to use the 5210 message every visit. 5 fruits and vegetables, less than 2 hours of screen time, 1 hour of physical activity, and 0 sweetened beverages. I just want to share a couple of other quick maternal and family directed recommendations from that nutrition guide. There should never be technology or TV in a kid's bedroom. Family style meals without technology. They say in this book, parents decide what is served food wise to a child. Children should be allowed to choose if they eat it or not, but there should be no special trips. Nobody gets to go to McDonald's because they didn't eat their supper. And it actually even goes as far as to say no French fries to any child under 1 years old. So again, you just digest that. The first time I read that, that was a little shocking to me. Now, back to our idea of mom and depression here. This is a screenshot so you can see it of that maternal depression recommendation. On the left-hand side, do you see where it says maternal depression screen circled in the purple here at 4? It's supposed to occur by 1 month, 2, 4, and 6. So I know that there's going to be pushback, right? But we need to get a workflow for this. This is something that our staff can do. This is not a burden of provider time. And we don't have to necessarily treat them that day. We screen to identify, we screen to get them referred. All we need to do is get them the next step of care. In my own clinic, I have a deal worked out. If I'm not doing the well child exam with my colleagues that are doing them, if mom is identified on our depression screening, they usually run down the hall and ask me if I can see her, fit her in. And that's what we do kind of as our workflow in our own office. But you could create any number of workflows here. You'll be hearing more, I believe, KPCA, you correct me if I'm wrong, but there are probably some resources coming down the pike about telehealth specific to maternal mental health that you'll be hearing more about from KPCA. So that might be another workflow integration that you can get into there. Now, how are you going to bill for this? I'm so glad you asked, right? Because we want to get paid for the work that we do. So here's how you do it. You're going to screenshot this QR code, which is going to take you to this document from AAP called Pediatric Preventative Care. It's a coding guideline. So I want you to turn to page 10 of that document. It speaks to health risk assessments. And if you read the footnotes of this slide, I copied and pasted from that document so you can have real quick and real easy access to it. But at these pediatric visits, when we are screening for maternal depression, as we should already be, then here's the code that we're going to use. It's the 96161 Administration of Caregiver Focused Health Risk Assessment. They specifically mention a depression inventory. You can use any inventory you want. You can use Edinburgh. I particularly recommend that you use PHQ Q2 or PHQ9 because you're already using those in the pediatric side, and that's not a heavy lift for those providers. But this does need to be billed under the baby's name. Even though we're screening mom, screening the caregiver, it gets documented under the baby's chart. So I want to be clear about that. You'll add your Z code in there, and it is not limited just to depression. So the language of that, I'm going to encourage our organizations to push these payers a little bit and say, hey, this CPT code and these billing codes, they're not limited to depression. They can include suicide, alcohol abuse, and they can also apply to any caregiver of the child. So it could be grandparent, it could be paternal, meaning dad, it could be any of those providers. So I encourage you, grab this code and let's start billing for it. Now, I know what the providers are going to say, and I mean, I know how it goes. And this is, they say, well, I can't, and I don't have enough time. And we know this from evidence. In this particular study, they interviewed 688 pediatricians. 83% said they were screening. I kind of find that number hard to believe, but okay. 44% they were using a valid instrument. But here's all the pushback they were giving your leadership team, giving their leadership teams, right? So many of them believe it's not an appropriate role for a pediatrician to screen for maternal depression. Hard to prioritize time. It was not already built into the electronic health record. They have lack of knowledge on referral options. That may be fair to them. Lack of treatment options on positive screens, and they've just overall had no training. In this different group, 80+% of pediatric providers say they've had no training in maternal depression. So the good news for you and I is we can fix all of these things. And especially leadership, C-suite, you can fix all of these. Next slide, please. So here's what I want you to take back is this flipped attitude and say, thanks to the good leadership in my organization, now we can. So in our clinic, it's not my role as a pediatrician. Well, yes, it is actually because AAP said so. And I know that's a little third grade, but it's in the guideline. AAP says it is your role. It's all of our jobs to take care of these families. We care about the baby. We got to care about the mom. They are not a separate entity, right? Difficulty prioritizing time. Well, good news for your providers. This isn't taking up their time. This is taking up nursing time. This is taking up MA screening time, but it's not provider time. This should really be protocoled out and just part of the workflow. It shouldn't be any kind of a lift for the provider. If it's not in your EHR, I'm so sorry, but just do it on paper and scan it in. No excuse, or build it into your electronic health record if you're able to do that. Just remember it goes in baby's chart, not mom's. And then what's the referral options? This is easy too, because yes, we need to train our primary care providers more on what they can do for maternal mental health. I get that, and I agree that that's a need. But the referral from pediatrics is really just, mom, you need to see your primary care provider and or your OBGYN. That's easy. And you could also potentially offer that telehealth in the future to that maternal mental health resource. More on that later. What are we going to do about the positive screens? You do not have to actively treat them. You've just got to get them to the next level of care. Make sure they're not suicidal or homicidal, right? But really, it's just screen them, refer them. It's that easy. You don't have to check them in for a full-on visit unless you're going to full-on see mom. You just need to ask those simple questions, check a blood pressure, train them, get them to the next level of care. It's easy. And all of that is in your Bright Future resource that KPCA is going to purchase for you or is willing to purchase for you. Now, on the note of maternal hypertension, I'm going to put to us, could we add that? So at these visits where we are already doing maternal depression screening, let's just check a blood pressure. It's easy. It's the same thing if someone walked into the front desk of our clinics and said, can I just have a nurse come check my blood pressure? It's that easy. It's no provider lift. Let's add that maternal blood pressure. Is there a log? But let's not miss mom and her hypertensive postpartum self while she's right under our noses during these pediatric visits. That's my only point. We can develop those workflows same day telehealth for hypertension the same way that we can work on it for depression. There are other opportunities that I want you to look for with this funding that we're getting from the Rural Health Transformation, right? Part of that is from the idea of mobile integrated health, where we are taking maybe community paramedics. There's a training for that coming up at EKU this summer. Check out EKU for that. Community health workers, training for that. Oregon is even getting NPIs for some of these providers. It's a partnership with primary care driven, but there is an opportunity for us to expand those programs to speak to maternal depression, maternal hypertension. Right now, most of the Kentucky programs are urban 911 based and not really focused on these outcomes, but there are other organizations that's knocking this out of the park. Next slide. In your spare time, I want you to watch this video and go and look at this exemplar from Grady Memorial, one of the largest health systems in Atlanta, but rural Georgia is having big time problems with maternal health, particularly hypertension. That's a big population that they address, but this is a model. They are using community paramedics, community health workers, and they're seeing big time reductions in their maternal health outcomes. So just take a look at that as you look at this money and how you're going to spend that in your areas. So just in summary, I know Bright Futures is for the kids, but there's parts of it that are for mom. Make sure that you're at least doing the depression screenings and billing correctly for it, as it already says that we should be doing that. If you want to be the Kentucky superstar, please think about adding on that very simple maternal depression screening. I'm sorry, hypertension screening when you're doing the depression screening. And let's look at those MIH partnerships as you incorporate all of that in the future. Just a few references for you. My contact information, you can take a picture of those slides and I'll turn it back over to Ashley and Chuck. And I think they're going to walk you through how you can go and order your copy. It's free. Don't you want something that's almost $100 that's free? I know I do as a provider. Um, I like free stuff, and it's just a big part of what we should all be already doing. So that's my speech.
Thank you so much, Molly. Everybody, I'm going to drop in the chat a link for an evaluation and then also a link to request the materials. Those of you that had already registered, Sally sent out those materials a couple weeks ago, so hopefully you've received them in the mail. And if you haven't, please email me and we will make sure to get that to you. Drop these links in here.
And for our FQHC members that are on the call, for our Kentucky FQHC members, we do have some grant dollars to support funding for Bright Futures manuals for each of your providers, not just your maternal health or OBGYN providers, but all of your providers. So if you get us a name and an address and an email in the form, we want to make sure that your providers have this resource at no cost.
I put both of those in there and I'll also send those out again because I know several weren't able to jump on that had originally registered. So I'm going to share the recording and those links also. Thank you guys. Have a good day.
Thanks.
Thanks for attending.